Good evening, delegates and all the participants. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's Mixed Bag webinar, organized by Dr. Ritu ma'am. So it's my privilege to introduce Dr. Ritu Santwani ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is currently obstetrician and gynecologist and IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am.
Yeah. Thank you, Sahiti. And thank you, Shield Pharma, for providing the platform. From last 3 years, this webinar is going on. So today I am having three of my very dear friends, very eminent speakers. Friends, as we all know, always we gain something whenever we discuss some topic. So today my three friends from the three corners I have taken. One is my very dear friend, Dr. Ruhi Yasmin from Darbhanga. Ruhi is doing the excellent work in her field. Now, the Sahiti, please first you introduce Dr. Ruhi.
It's my privilege to introduce Dr. Ruhi Yasmin ma'am. Ma'am is currently the assistant professor and director Metro IVF and infertility specialist. Ma'am has done the MBBS in Sri Krishna Medical College,
Muzaffarpur.
Muzaffarpur, and
Yeah, she is having a work experience of Darbhanga Medical College and Hospital as assistant professor and have worked also as a senior resident in the same college. Yeah, please stop sharing. Yeah, yeah. So, Yasini has also joined. Okay, so we can introduce. So, warm welcome, dear Dr. Ruhi, because Dr. Ruhi is today is going to discuss with us a very important topic regarding the ovulation induction. As we all know, there are a lot of queries each and everyone is having. Though we are doing the practice for so many years, everyone has a some or the other query that what to do in this case, how to manage this case. So, Dr. Ruhi is going to discuss with us regarding that. And other my dear friends, Dr. Sini has joined. Sini is a master
Hello.
of knowledge, I can say.
No,
Yeah, hi
no,
Sini, warm
nothing, nothing.
welcome. Warm welcome.
Thank
Huh?
you. Thank you,
Yeah.
Ritu. So
So
nice to see you.
uh,
Hello,
today
Dr. Rudy.
yeah. Today I have taken out three stalwarts from the three corners. My other third speaker has yet not joined.
Okay.
So uh, we will starting with the Dr. Ruhi and Dr. Sini, your introduction before your talk we will do.
Yeah, sure,
Yeah.
sure.
Yeah. Over to you, Dr. Ruhi. The dais is all yours. Later on, we will take the questions.
A very good afternoon and warm welcome to all of you. I would like to give my respect and gratitude to Dr. Ritu Madam and a lot of thank you, ma'am, for such a kind words for me.
You
Now
deserve
I
that, dear.
thank you, ma'am. Can I share my slide, ma'am?
Yes, 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 please.
Mhm.
Any problem?
No, no, no. Just a minute, ma'am. Please.
Okay, no problem. So, friends, meanwhile, Dr. Ruhi is sharing her PPT. Today, all the three topics are very important. Dr. Sindhi is going to enlighten us about the thyroid and infertility. We all know daily in our OPD, we are getting the patients related to that. So, I think she started the sharing. So, yeah, screen is visible and only you make it full screen. Only this button you have to click. See, I have pointed the arrow.
Just a minute.
Yeah, okay, no problem.
Yeah, okay, ma'am. Today I am going to talk about a very important topic,
ma'am,
basics of.
it's not in full screen, ma'am. Kindly make it in full screen, ma'am.
Already full screen, no?
No, ma'am.
See,
Here
click
is
this.
full screen, ma'am.
See,
It's not full screen.
No, ma'am.
no.
Here is full screen, ma'am.
Ma'am, kindly reshare it, ma'am, once again.
Sure. Okay, okay.
Ma'am, please stop share and then start sharing again, ma'am.
Now it's visible. Is visible full screen, ma'am?
No, ma'am.
No.
It's not
But
full
here,
screen, but slides are visible. No problem. You start. Please start. Huh? If you can click this button, see if you can click this button down. Is it visible to you?
yeah, ma'am.
This arrow, if you can click this. You are using the laptop or this iPad.
Am I audible, ma'am? Hello?
No, ma'am.
No, no.
It's not in full screen, ma'am.
Not visible.
No problem. You please carry on. Please carry on. We are able to see some important things. Please start, Dr. Louis.
Okay, okay. Today I am going to talk about, sorry for delay. Today I am
No
going to talk about basics of ovulation induction and stimulation. This topic is very close to my heart. Then question is, what is ovulation induction? Ovulation induction is development of one dominant follicle to cause ovulation in women who do not ovulate naturally on their own. Then where do we need it? Ovulation induction, we need it in first anovulatory PCOS, in hyperprolactinemia, in hypogonadotropic hypogonadism, and less defined anovulation, that is subtypical PCOS, subtypical hypo, and extremes of age. In hypogonadotropic hypogonadism, there is gonadotropin deficiency, so there is not follicular development. And in hyperprolactinemia, the same things happen here, where gonadotropin releasing hormone, inhibitory effect on gonadotropin releasing hormone. So also here gonadotropin stops. Now the question is there any other parallel technique of ovulation induction? Yes, other is the ovulation stimulation. It is the stimulation of ovulation for purpose of multifollicular development in who ovulate spontaneously or with medicines to increase the chance of pregnancy. And we use ovulation stimulation in IUI, where at least 2 dominant follicles is needed, and in IVF, where 10 to 15 follicles required. And the other synonyms.
Sorry to disturb you, ma'am. Slides are not moving, ma'am.
Slides are not moving. Not moving, ma'am?
Not moving, ma'am.
How to do it?
Ma'am, let me guide you, ma'am. So after sharing the screen, you need to click on the screen tab, ma'am, which is on the top left. If you click on the screen tab
Yeah.
and then click on share,
Yes, ma'am.
After clicking share screen option, you need to click on screen tab, which is on top left.
Left.
Can you see it, ma'am? Screen tab.
Yeah.
Click on that, ma'am, and then share. Super, ma'am. Perfect. Now we are seeing
Thank
full
you.
screen. Thank you, ma'am.
Yes, perfect. Please continue.
Sorry for interruption.
No
Is
problem. No problem.
any other parallel technique for ovulation induction? Yes. The parallel techniques, others are ovulation stimulation, ovulation hyper stimulation, controlled ovarian hyperstimulation, and controlled ovarian stimulation. Stimulation of ovulation for the purpose of multifollicular development, in which more than one dominant follicle is needed to increase the chance of pregnancy. And it is needed in IUI and IVF cycle. In IUI cycle, we need at least 2 dominant follicles, and in IVF, at least 10 to 15 dominant follicles needed. The controlled ovarian hyperstimulation and controlled ovarian stimulation. Here we put the word C because here external drugs are used for controlling the protocol and stimulation, and it is used in IVF cycle.
Double click on the slide, ma'am.
Now the difference in drugs used for ovulation induction and stimulation. The drugs used for induction are clomiphene citrate, aromatase inhibitor like letrozole and anastrozole, gonadotropins, and dopamine agonist used in hyperprolactinemia. Clomiphene citrate is a selective estrogen receptor modulator, acts on the estrogen receptors and long half-life, about 1 week or 4 to 5 days, and the aromatase inhibitor is letrozole used. Both drugs are used for 5 days, and the dose is 2.5 milligram per day, and it acts by inhibiting the enzyme aromatase and cause hypoestrogenic condition. And gonadotropins like HMG, FSH, recombinant FSH, highly purified HMG, and dopamine agonist used in hyperprolactinemia like cavagoline. And the drug used for ovulation stimulation, the oral agents here also are clomiphene citrate, aromatase inhibitor, or gonadotropins. For IUI, with aim to make 2 dominant follicles to increase the chance of pregnancy. Gonadotropins with gonadotropin releasing hormone analogs for controlled ovarian stimulation in IVF to make 10 to 15 follicles to get at least, and it gives 10 to 15, about 10 to 15 embryo, and get at least 1 euploid blastome. Difference in methods of ovulation induction and ovulation stimulation. In ovulation induction, there is no need to suppress LSR before ovulation is allowed, because here couple is asked to have natural sexual intercourse. So we don't care when the surge happen, when the ovulation happen, because the sperm supposedly accumulate in the genital tract and cervical canal, and she can get pregnant. Here also trigger is not mandatory because trigger given for timed ovulation precisely, and here we don't fix the time for ovulation because the couple is naturally have intercourse. And also lower risk of OHSS in ovarian hyperstimulation syndrome in ovulation induction. Is occurs dependent on the intensity of ovulatory response, drug and doses used. But it can occur also in ovulation induction if we use the drug absolutely uncaringly. That is when high dose of drugs are used, or the ovarian response are very high, and then it can happen also in ovulation induction. Ovulation stimulation. In ovulation stimulation, LSR needs to be controlled in IVF cycles, but rarely in IUI cycles, only to overcome weakened IUI. LSR usually controlled in IVF cycle because after 36 hours of trigger, OM pickup has done. But in IUI cycle also it can be controlled in case of when we want to do weekend IUI. When we feel on Friday there is 17 to 18 mm oocytes and on Saturday we want to prevent LS surge, then we can give anti to prevent LS surge. So we can do weekend IUI. Ovulation trigger is required to time ovulation precisely. Higher risk of ovarian hyperstimulation syndrome, independent of PCOS, may occur in any patients where estradiol level is very high. This is the very simple picture, graphic representation of a natural cycle or in ovulation induction. Look at this picture. We see on day 1 of menstruation, the serum estrogen, estradiol, and serum progesterone and serum FSH levels are very low. Then there is due to low level of estrogen, the positive feedback on the pituitary and FSH level starts to rise, which causes selection of dominant follicles from already cohort of follicles. The dominant follicle has a maximum number of FSH receptors. Then as the dominant follicle grows, the E2 level starts to rise and it causes negative feedback and FSH level becomes plateau. Then other follicle undergo atresia. There is no selection of other follicles become dominant. So only one follicle here ovulate when it become mature and couples have sexual intercourse and get pregnant. This is the natural cycle or in simple ovulation induction. But in other case, when we give 5 tablets of oral ovulogens, then what happens? We can also see here the low level of estrogen, progesterone, FSH on the day 1 of menses. Here we give 5 tablets of oral ovulogens. And these 5 tablets for 5 days. And this continues to keep E2 level low. And this E2 level continues FSH rise. So there is no FSH plateau here. And more than one dominant follicle selected here. And this follicle when become mature and LS surge happen and ovulation happen and patient after intercourse get pregnant. Steps to start now come in the patient of PCOS with amenorrhea. Steps to start ovulation induction with clomifene citrate or letrozole in PCOS patients with amenorrhea. When amenorrhea patient come with amenorrhea, first we have to do urine pregnancy test to rule out pregnancy, and then do transvaginal sonography to see endometrial thickness first. If endometrial thickness is more than 5 mm, with the silent ovary, that is not any cyst, give progesterone, that is medroxyprogesterone estate 10 mg BD to induce withdrawal bleeding. Endometrial thickness, if less than 5 mm or equal to 5 mm, start stimulation. We can start stimulation directly or give OCPs 21 days for withdrawal bleeding, because in that thin endometrium, by progesterone of 5 days means cannot happen. So we give OCP for 21 days for patient satisfaction, psychological, because psychological things happens in mind and patient feels better after getting menstruation. So we can give ovulation induction after starting menstruation. Otherwise, we can start directly without the menses. Ovulation induction or ovulation stimulation started by day 2 to day 5 of the cycle. Longer the clomifene citrate free period before ovulation if started early. Because the clomifene citrate has longer half-life, and when we started early, then between ovulation and the stoppage of drug, there we can get more time. There is not any peripheral anti-estrogenic effect on the endometrium and cervical mucus and there is no thin endometrium. The thickness of endometrium becomes adequate. Ovulation induction can be started on any day post menses with variable results in anovulatory PCOS after ruling out pregnancy. Now the question is administration of clomifene letrogen PCOS women and ovulatory PCOS. Starting dose for clomifene is 50 milligram per day. Letrozole is 2.5 milligram per day for 5 days. Increased dose for clomifene to 100 milligram or letrozole 5 milligram per day in subsequent cycle if no ovulation. No need to increase dose if ovulation happens with clomifene 50 or letrozole 2.5 milligram per day, because there may be a patient may land up with ovarian hyperstimulation syndrome. So if ovulation in lower dose, no need to increase the dose. 3 cycles, in 3 cycles, if no ovulation with clomifene citrate 100 milligram per day or letrozole 5 milligram per day, revise strategy of treatment in the next cycle. Maximum dose allowed of clomifene citrate is 500 milligram in 1 cycle, not more than that. Now the duration of treatment with clomifene citrate. If no pregnancy, clomifene failure, it's called clomifene failure. If no ovulation, it's called clomifene resistance. It is limited to 6 ovulatory cycles, but we can't wait for 6 cycles for clomifene resistance. We usually do it for 3 cycles. Then we look for other device treatment. Absence of pregnancy. In absence of pregnancy by clomifene citrate or letrozole, then we look for second line therapy. That is administration of gonadotropin with or without ovulogens. Either in the form of we add gonadotropin on day 3. That is start ovulation from day 2 to day 6, and gonadotropin either add on day 3 and day 7, or after completion of oral ovulation, that is on day 7, on alternate day 2 to 3 injections. And other medical pre-treatment metformin. Letrozole with metformin acts pretty well. Metformin or make her run, make her walk, or do anything which makes the ovary sensitive. We usually use metformin when BMI more than 40. BMI more than 30 and glucose insulin ratio less than 4.5, fasting insulin more than 22, or metabolic established patients. Surgical pre-treatment, laparoscopic ovarian drilling. It's not first line treatment. Laparoscopic ovarian drilling is always it's a third line treatment in which there is ovary is very resistant, very high volume ovary, and patients is young, patients thin, slim patients, young patient, and not ovulating patient, non-ovulating patient. Then we can do laparoscopic ovarian drilling, but this would be very judicious for laparoscopic ovarian drilling because we should not frad all the ovary. We should do by international endoscopic guideline. We should do only 4-4-40 rule. That is only 4 puncture for 4 seconds by 40 watt. And cumulative live birth rates. And by laparoscopic ovarian drilling after LOD, 50% patients ovulate thereon. And the cumulative live birth rate after are 50 to 60% with clomifene citrate for up to 6 cycles. Now the question: how do you or your patient monitor cycles with use of clomifene citrate or letrozole? Is it clinician monitoring? Every monitoring cycle should be monitored by clinicians. Yes, it should be monitored by transvaginal sonography before a start of drug. First TVS before start of drug. That is on day 2 of menses. Ensure endometrial setting, that is 4 mm or less, and no persistent ovarian cyst more than 10 mm. Restart monitoring from day 11. Then every 2 to 4 days till ovulation. Last monitoring day 21, no follicle selected, or if serum progesterone on day 21 is less than 1 nanogram per ml, give withdrawal bleeding by medroxyprogesterone state for 5 days. A lot of my patients self-monitoring. A lot of my patients came to me and get their ovulation stimulation and go back to their cities or villages. Then what do I do? We give them for LS Surge kit, LS Surge urinary kit. It's not very cheap. It contains about it's contain 5 stripes in which the LS Surge she check her search from start from day 11 on every alternate day till day 21. If such not happen, then we give her medroxyprogesterone acetate for withdrawal bleeding, and then wait for menses. That is day 21 to day 26. We give medroxyprogesterone acetate and wait for day 36. If patient if patient didn't get menses, then it is mandated that we should check her her by urine pregnancy test, because there might be missed ovulation and patient could be pregnant. So it is very important that always couple ask to have natural sexual intercourse on any random day, not only timed intercourse, because timed intercourse causes very pressure on the couple's mind and the performance becomes ill. But LS Surge kit is not very reliable, because sometimes, most of the time, LS Surge happen in the morning. So in some, it may be in the afternoon, or in some, it may be in the evening. Other way of checking LS Surge is serum progesterone level on day 21. If it is less than 1, there is then we give withdrawal bleeding. If it is more than 3, 4, 5, then we do we should check urine pregnancy test after 15 days. Principles of gonadotropin regimens used in PCOS patients.
Dr. Ruhi, yeah,
Yes.
excellent presentation going on, but sorry to interrupt you, as program schedule is for 1 hour, half an hour is going to finish. So please
Yes.
summarize. Still two
Yes,
speakers
yes.
are there. Yeah. Huh.
Principles of gonadotropin used in PCOS, it should be gonadotropin should be chronic low dose regimen used in step up, step down, and constant dose regimen. These regimens fulfill 2 essential requirements for successful ovulation induction in PCOS: allow slow rise of FSH to just above the FSH threshold level, not double the FSH gonadotropin, because it may land up in ovarian hyperstimulation syndrome. Avoid explosive ovarian response because of specific sensitivity of PCOS to exogenous gonadotropin. Now, question is which gonadotropin used? A lot of data, a lot of research have done, and it has been concluded by Cochrane 2011 also. You can use any of the gonadotropins that is highly purified HMG or FSH, urinary FSH, or recombinant FSH. But only difference is that in recombinant FSH, there is no batch to batch variation, and we can break the dose as small as 8 unit or 25 unit as in PCOS patient. How do you use gonadotropin PCOS women for ovulation induction? Can you monitor without ultrasound? No. Every gonadotropin cycle should be monitored by ultrasonography. Low starting dose of gonadotropin and small increments by 25 to 50 IU gonadotropin dose are desirable after first 5 days of constant dose administration. Ultrasound monitoring is a must before starting gonadotropin, and then 5 days after gonadotropin administration, then every 2 to 3 days. Trigger not needed if 1 to 2 dominant follicle, and sexual intercourse is mandatory, not IUI. Use of gonadotropin, there are 2 types of response in PCOS patient, as seen in the picture. In first type of response, there is, as you can see, after 5 doses of gonadotropin on day 6 of ovulation, there is 1 dominant follicle emerges and a beautiful triple line. And then we continue the gonadotropin till 15 mm of follicle. Then it grows itself, and when it becomes mature, ovulate, and patients get pregnant. But in other type, it is very resistant PCOS, in which we can see on day 6 of stimulation, there is no any dominant follicle emerges. Then we increase the dose of FSH, but we cannot get any dominant follicle till day 18 to day 25. Then this type of patients either refer to specialist or check this type of patient of day 2 FSH LH. It may be hypo or receptor polyformism. In this type of patient, we give a high dose of human menopausal gonadotropin or add recombinant LH. It is necessary in patients having received ovulation induction PCOS. Is IUI necessary in these patients? No, not SCG necessary, not IUI necessary in this patient, because here he asked the couple for natural sexual intercourse, and we don't care when surge happen, when ovulation happen. Ovarian ovulation in IUI. Here the rationale is to increase the number of oocytes, to increase the chance of pregnancy, higher concentration of energy-laden sperms at the site of fertilization, because the there is we found this fundus of the uterus is the sperm palate, site of sperm palate, where the sperm rapidly move towards the tube or hole inside the uterine cavity or crypts of endometrium, but which move towards the oocytes in the tube is very much less than other sperms, which is very high energy laden sperms, and is being capacitated and which fertilize the ova. Format are used for IUI and clonophenol citate, letrozole, and gonadotropins. It is a good option in patients having received ovulation induction by any drug, including gonadotropin, undergoing IUI. Yes. Because here we want to time the ovulation precisely, and we want to control the ovulation time. The last word to ovulation induction. If the diagnosis is correct, most cases will ovulate. That is, maybe PCOS patient, maybe hypogonadotropin, hypogonadism, it may be hypoprolactinemia. Then we give ovulation induction according to the diagnosis. Aim is not to achieve ovulation at the cost of increase in complication like ovarian hyperstimulation syndrome or multiple pregnancy. That is, we do not just double the dose of gonadotropin. We should slow increase the dose. Days taken to ovulate do not matter. It usually happen in PCOS patients, which are very irregular period, and she can ovulate on any random day. So we should not, when we monitor the cycle, and we give 5 days of ovulation, and we see on on day 11 if there is no any dominant follicle till day 17, then we can add day 17, day 18, day 19 gonadotropin, and then it may follicle grow and ovulate on day 25, day 26, day 30. Doesn't matter. Patients have natural intercourse and she can conceive. So it usually happens PCOS girls. We can save the same cycle. Ovulation induction is not only a science, but a piece of art. The more you treat the patients, the more you get insight into their ovulation types. So you find that it's not very complicated, not very easy. Thank you so much for your patience hearing, ma'am. Thank you. Hello.
Yeah, thank you, Dr. Ruhi. Thank you, Dr. Ruhi. Yes, very excellent presentation. The last line is, of course, very catchy. Ovulation induction is not only a science, but a piece of art. Please stop sharing your screen.
At 6 p.m.
Yeah. Sahiti, will you please show the certificate?
Yes, ma'am.
This is a certificate of appreciation from our side to the speaker. Dr. Ruhi, this is for you for contributing as a distinguished speaker for this today's webinar. Thank you. We will take the questions at the end. Thank you, Dr. Ruhi.
Thank you, ma'am. Thank you, ma'am.
Yeah, now we are having our other second speaker with us, my dear Preeti, whom I call her Jhansi ki Rani. So, yeah, Saiti, please introduce Dr. Preeti.
Okay, ma'am. It's my privilege to introduce Dr. Preeti Gupta, ma'am. Ma'am is the currently Director Lakshman Seth Hospital and IVF Center and Director of Dr. Preeti Global University. And ma'am has been awarded the Best IVF Center in Bundelkhand region in 2018 by International Business Awards at Gurgaon. First one in Bundelkhand region to have an IUI lab, IVF and ICSI lab. And ma'am has been running her own private university with the name Preeti Global University and has been faculty in national and international conferences of Foxy and ISA, has been awarded as the Corona Warrior by IMA Jhansi and Manikarnika Award by Sai Women and Welfare Society in 2021. Ma'am has received numerous awards and also organized many hands-on workshops at centers like hysteroscopy by Osama Shaki and many other doctors, and also has been awarded MRS Mrs. Jhansi in 2018 and Jhansi Ratn in 2012. I welcome you, ma'am.
Thank you so
Wow.
much.
Yeah, warm welcome, dear Preeti. Preeti is a dear friend. So, Preeti is the one who has taken the Bundelkhand into the heights. So, we always call her my Jhansi ki Rani. Huh? So, she is doing excellent. Yeah.
As a friend, so blessed.
Yeah, she is doing excellent work in the field of the infertility. So now, as we all know, related to PRP, we are doing the PRP for the thin endometrium, for the ovarian rejuvenation. So lot of scope for this PRP. So let's first hear from Dr. Preeti, and later on we can take the questions. Over to you, Dr. Preeti. Yeah.
Dr. Ritu, can you help me how I have to show my slides?
Yes. Sahiti? Sahiti? See, we're able to see this share screen down button. Sahiti, are you there? See this button, are you able to see the share screen? Green
You're
color.
talking to me? You're talking to me?
Yes, I'm talking. You
Ma'am,
joined.
I have made you co-host, ma'am. Now please check once again, ma'am.
You guide her.
I'm not able to see share screen.
Have you joined from the mobile?
Yes, I have joined from the mobile.
Ma'am, please click on share screen option, ma'am, which is in green color at the down of the mobile. There will be some options, like at least click on more option. You can sometimes see share screen option there.
No, I don't have. Actually, I have opened on my laptop also, but I have not joined the meeting from that.
Meanwhile, I think you will join from the laptop. From mobile, how can she share? Sahiti?
Same way, ma'am. Share screen
Acha.
option also will be there in
So
mobile also.
I need to join from the laptop.
Yes, ma'am. It will be better, ma'am.
Priyanka, एक second, Aishwarya को बुला दो।
So meanwhile, we will start with Dr. Sini. Preeti, you will carry on because the time is up to 4:30.
Yeah.
So we will, because Dr. Sini is also there. Yeah. Yeah.
That's fine.
So, yeah. Warm welcome, my dear friend Sini. Sini is doing a great work in the infertility. Today, she is going to discuss with us a very important topic, thyroid and infertility. Yeah, please introduce Sahiti.
It's my honor to introduce Dr. Sini Venugopal, ma'am. Ma'am is the Medical Director and Fertility Consultant at Genix Fertility Center, Bhubaneswar. Ma'am is Cosmetic Gynecologist at Genix Aesthetica, Bhubaneswar. Former Associate Professor, High Tech Medical College, Bhubaneswar. And ma'am has done Fellowship in ART, Fellowship in Laparoscopy, Hysteroscopy, Diploma in Cosmetic Gynecology at Indian College of Cosmetic Gynecology. Ma'am has done training in cosmetic gynecology, Israel. Ma'am has received ISA Rising Star Award at Annual ISA 2024 Bhubaneswar. And ma'am is the organizing committee member of Annual ISA 2024, Quiz Master for that the same, and publications in national and international journals, contributed chapters in various Foxy books, and committee member of Foxy Endocrinology Committee, and also invited faculty at various national and international conferences. I welcome you, ma'am.
Thank you so
Warm
much
welcome, dear
for
Sydney.
the
We
warm
all are
words.
we all are eagerly waiting to hear you. The topic is very close to our heart because each and every one of us having a problem while treating the thyroid and infertility. Over
Yeah.
to you, dear.
Yeah, sure. Just a second. Can you?
Yeah, no problem.
Share screen.
Friends, meanwhile, if you are having any questions related to these three topics, do post in the chat box, so I will take once the session is over.
Slideshow. Switch. Can you see the slide, Ritu?
No,
Dr. Ritu?
no, dear.
I cannot see. You are sharing the screen. It's written you are sharing the screen. Share. Stop share. ସେଟା ତଳେ ଆମେ ମିନିମାଇଜ କରିକି ରଖି ଦେଇଥିଲେ ତଳୁ କାଢିଥାନ୍ତା.
Allow me in the meeting.
Just a second.
Dr. Ritu,
Yes, Preeti.
please allow me. I am joining from my laptop.
Ajha, Sahiti, please allow her. Huh? You are already co-host, Dr. Preeti, so I don't think you
No,
need
no.
any.
Okay.
Whosoever is ready is first, Dr. Preeti or Dr. Sini, we will take them. Huh.
Problem is only of slide share. If you can share your screen, otherwise she's just trying. It will take hardly a minute.
Acha, okay. Yeah,
Yeah,
Sini. Dr. Sini, only make it full screen. Sahiti, you can guide them.
Yes, ma'am. Please click on from beginning, ma'am, which is in the top left. From beginning. Yes,
Yes.
ma'am. Yes, ma'am.
Yes. Yes, Sini, you can start, please. Slides are visible.
If there is a problem, I can speak without slides also.
No, slides we must show. A lot of doctors have joined across that. Huh.
Ma'am, please double click on the screen, ma'am, to move the slides. Yes, ma'am, we can see the slides, ma'am. Sini, ma'am. Please unmute, ma'am.
Cindy, any problem?
Are you able to hear?
Yes,
ma'am,
yes,
now we
yes,
can hear, ma'am.
yes.
Okay, okay. So the topic today is thyroid and infertility. So here we'll be discussing about the physiological interactions, the thyroid hormone does with the various reproductive hormones and the reproductive system of male as well as the female. So how it influences the fertility status of male and female. So human fertility and implantation, they are determined by complex regulatory, endocrine, and immune factors. There are various factors of female and male infertility, and researchers have tried to identify the treatable risk factors that contribute to infertility. And among these, thyroid disorders, that is both thyroid dysfunction and autoimmunity, they show a high prevalence in women of reproductive age group. And the most best thing about thyroid, dysfunction is that it is a very treatable risk factors, because there are so many risk factors which are very difficult to treat. So identifying and properly timely identification and to know when to treat, whom to screen, this is very important for thyroid dysfunction. So thyroid disorders, they are the most common endocrine problems in women. There is a known association between infertility and hypothyroidism, associated mainly with the ovulatory disturbance. And we all know that undiagnosed and untreated thyroid disease can lead to infertility and subfertility. So how it affects, so this is the various ways by which thyroid dysfunction can affect the fertility in women, that will ultimately result in anovulatory cycle, luteal phase defect, hyperprolactinemia, sex hormone imbalance. So thyroid disorders, it can be hypothyroidism and hyperthyroidism. Now, prevalence of thyroid disorders in the reproductive age group, subclinical hypo in 5 to 7%, overt hypothyroidism 2 to 4.5%, hyperthyroidism is seen in around 0.5 to 1%, and the thyroid autoimmunity seen in 5 to 10%. So here, as I said in the beginning, here today we'll be discussing about the thyroid hormone physiology and how it interacts with the female reproductive function. Thyroid hormones, they act at different levels and they affect the reproductive functions in women. We all know it acts on the hypothalamus and pituitary because there are the thyroid hormone receptors on the hypothalamus and pituitary. But it also acts on the ovary because the thyroid hormone receptors have been found on the human ovary surface epithelium as well as the granulosa cells. Thyroid hormones, they stimulate the proliferation of the granulosa cells and reduce the apoptosis by potentiating the FSH-mediated cell survival pathway. And these thyroid hormones, they also increase the FSH receptor expression in the preantral follicles, increases the expression of the cytochrome P450. And the thyroid hormones, they also regulate the secretion of the GnRH. Thyroid hormones, they also affect the biological availability of the sex steroids like estrogen, progesterone, androgens. TRH, TSH, T3, T4, they perform facilitatory roles at each level of the hypothalamo-pituitary gonadal axis. These thyroid hormones, they also mediate the endometrial proliferation, and the thyroid hormones, they support the insulin's influence over the hypothalamo-pituitary gonadal axis. And we all know insulin has a stimulatory effect on the GnRH. Thyroid hormones, they mediate expression of the ovarian matrix metalloproteinases, which are responsible for the disintegration of the extracellular matrix, which facilitate the ovulation or the oocyte release. Thyroid hormones, they also regulate a variety of biological processes like cell growth, cellular oxygen consumption, metabolism, embryonic development, tissue differentiation, and maturation. So as you can see here, hypothyroidism, Hypothyroidism, the levels of T3, T4 hormones will be less, which will lead to increased release of thyroid releasing hormone, TRH, which will ultimately cause increased secretion of the TSH. And at the same time, it will also cause increased release of prolactin, thereby also leading to hyperprolactinemia. And this increased prolactin has a negative effect on the GnRH pulse secretion. So it reduces the GnRH pulse secretion. So you can see that increased prolactin level, it reduces the GnRH pulse secretion by various methods. That is, this high prolactin directly acts on the GnRH neurons of hypothalamus. The high prolactin and directly acts also on the pituitary to directly reduce the secretion of the gonadotropins. And this high prolactin will also increase the dopamine release. Thereby, his dopamine is again a prolactin inhibitory factor. We know that. So again, this high dopamine will suppress the excitability of the GnRH neurons and cause reduced GnRH secretion. So you can see that in hypothyroidism, there is increased TSH levels, reduced thyroid hormones, and at the same time, there is associated high prolactin levels, which reduces the GnRH pulse secretion, thereby causing less of gonadotropin release and ovulatory dysfunction. So hypothyroidism, whether subclinical or overt, if it is inadequately treated, it can lead to adverse fertility outcomes, obstetrics, and fetal neurodevelopmental outcomes. Now the debate persists, like when to treat the women who are trying to conceive. Subclinical hypothyroidism, it is more prevalent in infertile, subfertile women. And what are the effects of this? It reduces the number of good grade embryos. It reduces implantation rate. And if we are giving a supplementation with levothyroxine, again, it has been seen that the number of good grade embryos are improved, implantation rate, live birth rate, everything improves. Now, overt hypothyroidism, it also causes multiple issues like, altered metabolic clearance of androstenedione, increase in the peripheral aromatization. There is a decrease in sex hormone binding globulin. And as we already discussed, overt hypothyroidism means there will be increase in prolactin, thereby ovulatory dysfunction. Now, hyperthyroidism, subclinical and overt. Actually, regarding hyperthyroidism, there is limited data in the literature. So the degree to which hyperthyroidism directly, if it is linked to fertility issues or not, is not very well known. But yes, with thyrotoxicosis and Graves' disease, these are conditions of hyperthyroidism. It has been seen that there is increased association of sex hormone binding globulin high levels, high estrogen, increased LH secretion. Now coming to the thyroid autoimmunity. Most common autoimmune disorder in women of reproductive age group is a thyroid autoimmunity, and it is a major cause of subclinical hypothyroidism. And it is very prevalent in women with idiopathic subfertility, PCOS, diminished ovarian reserve, and premature ovarian insufficiency. Two types of antibodies we see here, that is the thyroid peroxidase antibody and the thyroglobulin antibody. And mainly the thyroid peroxidase antibody high levels are seen in association with high TSH levels. Regarding the thyroglobulin antibody, the significance is not very certain whether it is directly linked to fertility issues. Now, what are the ASRM guidelines? Yes, according to the ASRM, there is good evidence that in patients who have TSH levels high, that is above 4 milli-international units per liter, in them, if you give levothyroxine supplementation therapy, it is associated with improved pregnancy rates, reduced miscarriage rates. So that is a good evidence. Then regarding when the TSH is between 2.5 and 4, and if you are giving levothyroxine supplementation, whether it will improve the pregnancy or miscarriage rates, there is insufficient evidence regarding this. Now regarding subclinical hypothyroidism, that is if the TSH levels are more than 4, yes, then there is fair evidence that it improves the pregnancy rates and miscarriage, reduces the miscarriage rates. And regarding the autoimmunity, that is the antibody, there is again fair evidence that these thyroid antibodies, they are associated with infertility and miscarriage. And in these thyroid antibody cases also, if the TSH levels are more than 2.5, there is fair evidence that giving a levothyroxine therapy will improve the pregnancy rates and reduce the miscarriage rates. And so what are the ASRM recommendations? That is, in infertile women who are attempting pregnancy, it is reasonable to test for TSH. And if the TSH is more than the Typically, if you can say that it is more than 4, then the patient should be treated with levothyroxine, and our aim should be to maintain the levels below 2.5. And if you're detecting antibody in suppose women who is getting themselves evaluated for other immune related causes of infertility, and they detected that the patient has an antibody, thyroid antibody, then you should check such patients for the TSH levels also. And in these antibody cases, if the TSH levels are more than 2.5, even in those cases, it is ideal to give a levothyroxine supplementation. And let us also look at certain guidelines, that is a European Thyroid Association guideline on thyroid disorders prior to and during the assisted reproductive technology 2021. So here also they have given certain recommendations like before ART procedure, what to do. They say that screen the woman for TSH and the thyroid autoimmunity. So before starting any ART procedure, screen the woman for TSH levels and the antibodies. And women with TSH levels more than 4 and the cases who are overt hypothyroidism, treat them with the levothyroxine, whether they have the antibody or not, treat them with levothyroxine. And in those cases where the TSH levels are more than 2.5 and they have the antibody, in those cases, they have asked to treat the cases by levothyroxine supplementation in a case-by-case manner at the physician discretion. And regarding ovarian stimulation, we need to understand another thing, that when we're doing ovarian stimulation, we all know there is supraphysiological levels of estrogen. What happens when there is elevated estrogen? This high estrogen will cause increased synthesis of the thyroid binding globulins. So the thyroid binding globulins are increased, and also it causes certain changes, that is sialyation of these binding globulins, which will thereby cause reduced clearance. So because of this supraphysiological estrogens, the thyroid binding globulin level synthesis increases and the clearance decreases. So what happens is that ultimately there is a net high amount of thyroid binding globulin. So the bound form of the hormones are more. The free T3, T4, the levels are less. So what happens is that because when the free T3, T4 less, it will cause, as per the feedback mechanism, it will cause increased release of TSH. So there can be subclinical hypothyroidism in some patients who may not be hypothyroid before starting ovarian stimulation. Once we do ovarian stimulation, they might develop this hypothyroidism. So ovarian stimulation, it negatively alters the thyroid function in women with hypothyroidism and or this autoimmunity. These effects, they last up to 3 months after ovarian stimulation. So what are the recommendations? That is, before starting ovarian stimulation, you treat. If the case is a case of overt hypothyroidism, treat it. Subclinical hypothyroidism, treat with levothyroxine. Even if it is an antibody case, whether the TSH levels are more than 4 or between 2.5 to 4, still, in all these cases, the recommendations are to treat with levothyroxine. And in all these cases, our aim should be to keep the TSH levels below 2.5. And another thing is that if the antibody case, the woman with thyroid antibodies already on treatment with levothyroxine before starting the stimulation, then following stimulation, you have to recheck their TSH levels. And if the woman is euthyroid without any antibody levels in her body, in such cases, after the ovarian stimulation, there is no recommendation to recheck the TSH levels. Now, is there any association between thyroid disorder and ovarian reserve? Yes, particularly with the antibody cases. Mainly, you can see that the thyroid antibody cases are mainly associated with the premature ovarian insufficiency, diminished ovarian reserve. So the recommendation by the European Thyroid Association is that in those women with premature ovarian insufficiency or diminished ovarian reserve, you screen these women for ovarian, that is thyroid dysfunction, as well as for the thyroid antibodies. Now coming to thyroid disorder and male subfertility. So hypo, and the antibodies, all of these, they have adverse effect on male infertility. But evidence regarding male infertility and thyroid disease is, of course, limited. But even among subfertile men, you can see that subclinical hypo is seen in around 7.4% men and hyperthyroidism seen in 3.7% men. Both hyperthyroidism and subclinical hypothyroidism, they will cause reduced mitochondrial activity, increased oxidative stress. And even in males, you can see that hypo and hyper, both, for both of these antibody thyroid autoimmunity is the most important cause. Hypothyroidism in males associated with delayed ejaculation, and abnormal semen parameters. And hyperthyroidism, it is associated with decreased libido, erectile dysfunction, premature ejaculation, and again abnormal semen parameters. So what are the recommendations here for the male fertility case, male patients who are attempting to conceive? That is the recommendation, the evidences are not very strong regarding screening all the males. So they say that it is against the European Thyroid Association is against the systematic screening for all men for TSH and the TPO antibody in subfertile men. So they say no need to screen all the men for TSH and TPO. Yes, but screening is required. In who it is required? It is required in certain subset of men. Who are they? That is, they say that screen for the thyroid dysfunction in those men who have the ejaculatory or erectile dysfunction, or in those men who have altered semen parameters. And they also suggest that not to postpone the ART, that is IVF or ICSI, in whether it is a overt or a subclinical hypo case in males. So as long as the semen parameters are not very severely affected, that is, we detect a hypo or subclinical or a overt hypothyroidism in a male, no need to wait till their hormone levels come to normal and then go for treatment. You can, of course, start the treatment, but right away we can go for ART. No need to postpone ART. Just if the semen parameters are normal, then go for ART. And another thing is after radio ablation iodine, yes, there is increased risk for sperm chromosomal abnormality. So the recommendation is to wait for at least 120 days before we start fertility treatment for the male. So to conclude, thyroid hormones, they have a very strong crosstalk with the reproductive hormones and the hypothalamic pituitary gonadal axis. Thyroid dysfunction is a common cause of infertility and recurrent miscarriage. Thyroid disorders need to be identified and treated in women who are attempting to conceive. Assessment of thyroid profile and prolactin levels should be done in the initial evaluation of women who are planning to conceive. So thank you very much.
Very nice presentation, Sydney, as usual. Huh? So
It was a
thank you
very
once
short
again.
talk.
No,
Yeah.
because see, the time schedule is of 1 hour because
Yeah.
everybody's in the hurry to
Yeah,
go to
yeah,
the
yeah.
evening OPD. So, yeah, Saiti, please show the certificate of appreciation for Dr. Sydney.
Yes, ma'am.
Thank you,
Thank you
Sydney,
so
for
much, Dr. Ritu.
most welcome, most welcome. Thank you once again. As we are having a shortage of time, so yes, over to you directly to my dear friend, Dr. Preeti. Yeah, Preeti, we all are eagerly waiting to hear you.
Yes, I'm just starting.
Yes.
Good evening, everybody. So today I'll be speaking on use of PRP in infertility. As we all know, it's a very hot topic nowadays, and the good thing is that it's really working. It does wonders in patients who have very low AMH and those patients whose endometrium is not, we have done everything, but it's not tri-laminar. I'm just trying to share my screen. My screen is visible?
Yes, ma'am. Yes, ma'am.
Yes.
Okay. So
Double click on the slide, ma'am, so that you can move the slides.
It's moving, right?
Yes, ma'am.
Okay. Just a second. Yeah. So we all know platelet-rich plasma. It is autologous PRP. Autologous PRP is derived from individuals' whole blood, then centrifuged to remove RBC. Remaining plasma has 5 to 10-fold higher concentration of growth factors than whole blood. No. Okay. एक मिनट यार I don't know what is happening. आगे बढ़ता जा रहा है. चला गया. So right now I will tell you how do we prepare PRP. It is very simple. We just take around 18 ml blood from the patient and put it in 2 conical tubes. And then we just add 1 ml, 1.5 ml of EDTA in each conical tube and centrifuge it for around 3000 RPM. And then the upper coat and the buffy coat, they are taken in a different test tube and then they are re-centrifuged at around 3000 RPM. And then what the pellet and the first layer we get, that is PRP, which we use. Now the mechanism of action of PRP is not completely known. Lab studies show that high concentration of growth factors in PRP can speed up the healing process. Growth factors promote wound healing by initiating following stages: tissue necrosis, resolution, chemotaxis, cell regeneration, cell proliferation and migration, extracellular matrix synthesis, remodeling, angiogenesis, and epithelialization. PRP is superior to recombinant human growth factor as platelet activation leads to release of multiple growth factors and differentiation factors. PRP in reproductive medicine, it is mainly nowadays used in premature ovarian failure and in thin endometrium. Researchers injected murine ovaries with growth factor and mature eggs appeared to develop from stem cells. Introduction of isolated growth factor bearing platelets directly into ovaries triggers resurgence in oocyte production. Treatment with PRP is ovarian rejuvenation. PRP is injected into ovary under ultrasound guidance, similar to ovum retrieval in IVF. Pantos et al. At ESHRE 2016 introduced ovarian rejuvenation. Injected PRP in 8 perimenopausal and premature ovarian failure women with poor ovarian reserve. Successful ovarian rejuvenation for 1 to 3 months was done, and after PRP treatment, we got wonderful results. They got wonderful results. All cases underwent natural IVF cycles with follicles of 15.20 to around 20.5. Resulting oocytes were inseminated by ICSI and all resulting embryos were cryopreserved. Recently, even I am using a lot. I have done around 5 to 10 patients in which in the initial cycle, I just got 1 follicle, but after PRP, I got around 8 follicles. So it's really promising. Now the PRP in ovarian torsion, that is actually not related to our infertility, so I'll skip. Endometrium. PRP has wonderful results for endometrium. For successful implantation, the right and adequate embryo-uterine dialogue is important. Endometrium acts as an interface for this process. Outcomes of IVF depend on several factors like ovarian reserve, maternal age, and endometrial receptivity. Endometrial markers ultrasonography is considered a safer choice due to non-invasive technique and universally available modality. The diagnosis of endometrial receptivity key criteria is endometrial pattern and endometrial thickness. Pre and post-ovulatory rise of progesterone heralds secretory changes in endometrium, and these are paralleled by changes in endometrial pattern. Endometrial thickness increases in the follicular phase, and endometrial character changes from a hypoechoic trilaminar one to a compact hyperechoic look post-ovulation. A trilaminar endometrium on the day of ovulation trigger is associated with an increased probability of pregnancy, while a hyperechoic character signals failure. Now, the diagnosis of endometrial receptivity, endometrial thickness is measured by TVS as maximal distance between echogenic interfaces of myometrium and endometrium in plane through central longitudinal axis of uterine body. Endometrial thickness of more than 7 mm at the time of embryo implantation is considered suboptimal in ART. With respect to endometrial pattern and endometrial receptivity, a triple line appearance or multilayered endometrium on day of ovulation trigger is defined as grade A or receptive, while a homogeneous appearance or non-multilayered endometrium is defined as grade C or non-receptive. Progesterone secretion initiates changes in endometrium that are reflected as homogeneous character near junctional zone and well-defined central echogenic line. This endometrial pattern seen on day of ovulation trigger is defined as grade B. Now, thin endometrium and relevance in ART, endometrial thickness has been used to predict possibility of pregnancy in ART cycles. A thin endometrium being associated with poor success rate after IVF irrespective of causative factor. Usually, thin endometrium is defined as less than 7 mm. A cutoff value of 6 mm and 8 mm is also used. Thickness of endometrium is associated with decreased vascularity, suggesting advanced age. Incidence of 5% is reported in women less than 40 years and 25% beyond age 40 in natural cycles. Pregnancies are also reported at 4 mm or 5 mm thickness, suggesting endometrial thickness and receptivity are not entirely interdependent. Now, platelet-rich plasma, I have already told you how we prepare. It is collected from peripheral veins and contains several growth factors such as vascular endothelial growth factor, epidermal growth factor, platelet-derived growth factor, transforming growth factor, and other cytokines that stimulate proliferation and growth. So it acts like a stem cell. And, procuring stem cell is very difficult, but making PRP is very easy and can be done in anybody's hospital who just have a centrifuge. Now, the available treatments for thin endometrium, as we already know, are extended estrogen treatment with adjuvant therapy, low-dose aspirin, vaginal sildenafil, vaginal pentoxifylline, intrauterine perfusion with GCSF, electroacupuncture, and PRP. These has been used for thin endometrium, but there isn't any proven evidence in this treatment. Intrauterine infusion of PRP, conventional hormone replacement therapy treatment cycles. Estradiol valerate at the dose of 6 mg per day was given on day 3 of menstrual cycle. Hysteroscopic examination to evaluate adhesions or polyp is done, and intrauterine infusion of PRP is done. Endometrial thickness is then measured after 72 hours. Protocols for preparation, I've already told, it is very easy. Just take around 18 ml blood, put it in 2 conical tubes around 99 ml, and then mix 1.5 ml, 1.5 ml sodium EDTA. Although it is not, researched that which is best, but I am using EDTA and I am getting good results. And then it is centrifuged for around 3000 to 4000 RPM for 15 minutes. And then the upper 2 layers are taken in different tube, and then they are re-centrifuged at for 15 minutes around 3000 RPM, and the pellet and the upper layer what we get that we collect and use for injection. PRP in refractive endometrium. Endometrial growth following inadequate ovarian stimulation may lead to poor results of IVF-ICSI cycles. Various strategies are suggested to improve endometrial thickness, especially in resistant cases. PRP is a novel therapy used for improving endometrial thickness. Colombo et al. Included 8 patients who underwent PRP treatment. After PRP application, endometrial thickness was satisfactory in 7 cases. Positive test for HCG was found in 6 women. Multiple implantation failures were caused by inefficient expression of adhesion molecules, which could be improved by PRP application. PRP in refractory endometrium. Zedemodres et al. Included 10 patients who had history of cancelled cycles due to inadequate endometrial growth, which was less than 7 mm. Endometrial thickness increased at 48 hours after first PRP application and reached more than 7 mm after second PRP application in all patients. Embryo transfer was carried out in all patients. 5 patients became pregnant, and in 4 of them, pregnancy progressed normally. Conclusion: PRP was effective for endometrial growth in patients with thin endometrium. PRP in repeated implantation failure. Intrauterine infusion of PRP may promote endometrial growth and receptivity. Nazari et al. Enrolled 20 participants with history of recurrent IVF failure to evaluate effectiveness of PRP in improving pregnancy rate. 18 of 20, that means 90%, became pregnant. 16 clinical pregnancies were recorded and their pregnancies were ongoing at the time of study. Conclusion: PRP was effective in improving pregnancy outcomes in RIF patients. Conclusion: current research is devoted to applying PRP preparation and enhancing endometrial environments for successful embryo transfer. Only a few studies have furnished comprehensive protocols for using PRP injections into ovaries to augment follicular functions. In relation to preparation of PRP for endometrial use, although there is more consistent description of the injection timing, a significant variation persists concerning day of menstrual cycle that women receive intrauterine PRP. Some research protocols involve administration during mid-follicular phase, whereas others have chosen a 2-day window before embryo transfer. This discrepancy underscores absence of clear scientific foundation, leaving the determination and optimization of ideal time for PRP administration unresolved. Comprehensive and robust assessment of long-term safety of novel treatments such as PRP in ART is imperative, particularly considering ongoing concerns that ART itself may elevate risk of birth defects. So thank you, that's all. But I can just say that PRP is really playing a good role. It has a promising role in nowadays scenario in which, it is very difficult to take a donor cycle. So patients of low MH, I have been doing a study. Presently, I have injected PRP in ovary of almost 4 to 5 patients, and they were patients of previous IVF failure also. So in one patient, I got 4 follicles, one beautiful blast was formed, and I transferred that, and the patient is pregnant. In one patient, in the initial cycles, I got just 2-3 follicles, but after PRP, I got 8 to 10 follicles. She is also pregnant. So it really,
Great.
yeah, and in patients who have multiple IVF failures, like in my center, if my patient fails twice, I do hysteroscopy and PRP installation, and they really become pregnant in almost 3rd or 4th cycle.
Thank you, Preeti, for excellent presentation. Please stop sharing.
Yeah.
So, Sahiti, please show the certificate of appreciation for Dr. Preeti.
Okay, ma'am.
So there is little spelling
Yeah.
mistake. She will correct. She will correct and send it.
That's an issue.
Yeah.
Not an
Sahiti, please correct the spelling and send it to
Okay,
me.
ma'am.
Then I will
Okay.
say. Dr. Preeti, one question.
Yes.
You have shown regarding the vaginal pentoxifylline. So, are you using in some of your patients vaginal pentoxifylline?
From the day I've started using PRP, because it is so easy to make and it has got wonderful results. In the patients, like if I am, I am giving estrogen and I have to do the transfer also because I am doing batch IVF. In those also, it gives wonderful results. You just have to give around 3 to 4 days prior. You have to buy time for endometrium to grow.
That's correct. Totally agreed.
Results.
I'm just asking you for
Oh,
the other query.
I'm not using
Has
it.
anybody has used Sydney? Have you used for that?
Yeah, pardon?
Have you used this pentoxifylline?
No. I don't use pentoxifylline. Yeah, I also I'm very much in favor of PRP.
Yeah.
And that is actually giving good results. And after that, hardly we need to use anything else. We already give the vaginal sildenafil. Apart from that, that is we give the Aliver tablets. But apart from that, nothing else. It is just PRP.
Okay. Dr. Gayatri has mentioned the comment that she is using that pentoxifylline. So what dosage you are using, Dr. Gayatri? Is it 400 mg per day you are using? As what I read in the literature that 400 mg per day. If you can write in the comment or can Dr. Ruhi, if you want to add something, you are most welcome. She is using 400 mg BD for how many days? Because I recently presented a paper in the Arab societies. There's a lot of controversy regarding the use of the pentoxifylline. तो जब आज प्रीति ने लिखा तो मुझे लगा अच्छा point है, we can discuss. So this 400 mg OD usually they are recommending for 5 days. But ठीक है, still Dr. Gayatri has mentioned that she is using from the day 2 till endometrial thickness improves. Okay. Now, other query related to ovarian rejuvenation. Yes, of course, we all are using this PRP for the ovarian rejuvenation. But some questions I'm taking which are very basic because this program is attended from the PG students up to the senior faculties. So, while using this ovarian regeneration, the PRP. Where are you installing, Dr. Preeti?
In ovary, in the stroma.
In the stroma. See, this point is also very.
By the use of ovum pickup needle, transvaginally and the short GA, I'm doing that. And I'm doing at intervals of around 1 month. So I prefer doing at least 3 times I inject PRP and then I take the patient for stimulation.
Yeah. There is one question I received in the YouTube. That is by Dr. Mohana. Dr. Mohana is joined from Bhubaneswar. Dr. Mohana's question.
Dr. Preeti, can I ask you one thing?
Yes.
So, what is your experience regarding the ovarian rejuvenation with PRP? Because for endometrial, it is very good actually. Because I routinely use.
Wonderful.
Because I have done, I have also done few cases of ovarian rejuvenation, but didn't get very encouraging results. So probably I was like not very.
Simi, right now I have 3 patients. One was 2 IVF failures and her
Mhm.
AMH was 0.1. She insisted that I won't go for donor. I counseled her a lot, but she said, no, I won't go for donor. I said, okay, then we will try this. And I did her 3 sittings of PRP. And then after 3 months, I did her stimulation. I got 4 eggs, 4 ovum, and 2 M2 were there. And just 1 blast was formed. But I transferred the 1 blast and she is pregnant right now.
Wonderful.
We've already seen cardiac activity and everything. And there is one more gynecologist. She was from US actually. She had come here and her sister had 8 IVF failures. So she was counseled, for the failures. So I did her IVF twice. She didn't conceive, but her husband has already left and we didn't have a semen. So she was that we will come back afterwards because it was not possible to, freeze the semen and bring it here. So I said, okay, I'll do your 1 PRP in the ovary because your AMH is very low. So I just did her 1 rejuvenation cycle and then she went back to US and then she came back after 6 months. In the initial 2 cycles, Simi, I just got 2 to 3 follicles. But to my wonders, there were around 10 to 12 follicles in the cycle.
Oh my God.
And I
Okay.
froze all because she was 2 times failure and then I transferred and she's pregnant right now and it's around 3 months.
That's
Okay.
great.
Okay.
So related to that, first one question I've received in the YouTube where the Dr. Mohana is asking that, Madam, how much you charge for the per sitting of the PRP for the ovarian rejuvenation?
To me,
Actually, that is little. Of course, now you are the speaker for this topic, no?
see, Dr. Ritu, I tell the patient that I am not charging anything from you. I am just charging for anesthesia and pickup needle and OT costs. So because they are my patients, so I charge 18,500 per sitting. That's it.
Okay. And one question from Dr. Gayatri that how much PRP you are injecting for the ovarian?
I take 2 ml. I inject 1 ml per ovary.
Yes, I inject usually up to 1.5 to 2. Yeah. So one more question she is having that how many punctures you are making per ovary?
Just 1 puncture for transferring.
Yeah. Yes. Yeah. I think with this we will wind off because this is the OPD time. So thank you to all of my 3 eminent speakers. We will, yeah. Thank you, Dr. Ruhi, Dr. Sini, Dr. Preeti, and thank you, dear Sahiti, for providing the platform, and thank you, Shil Pharma. So, friends, with this, we will wind up.